All right, so we have a full room here at the Party Center, our wonderful sponsor here at Boston University, and a full room there on Zoom with more people streaming in by the minute. I am pleased to welcome you as Director of the Global Health Politics Workshop with several of my steering committee members here, including Gauri Vijay Kumar, Verna Singh, and others, to our third installment of five workshop talks this semester. Today we have with us, we're honored to have with us Dr. Sapna Desai. She is Senior Fellow with the Population Council Institute in New Delhi, India. Come a very long way. Thank you for coming to be with us. And today she'll be talking about unnecessary hysterectomy in India, puzzling patterns around women's bodies and health systems. Please help me welcome Dr. Desai.
Thank you all. It's really a pleasure to be here. And it's also, I was telling Joe today, I'm really grateful for the opportunity to think about how to talk about this issue, which is it's specific to India, yet it's global as well. And there are principles that I think underline the way in which we think about women's health and women's bodies around the world. So it just gives me an opportunity to really think about different ways of going through and grappling with the puzzles that I grapple with in my work. So I'm really looking forward to your inputs and thoughts as well, and just different ways in which, how you react to it and what you think about it. And as I mentioned earlier, and for those of you on Zoom, hi, thank you so much for being here. And I was just saying that I normally do this in a public health audience, and I specifically try to ensure that it's not solely about the public health aspects or the epidemiologic aspects, but rather thinking about the issue much more holistically and within the realms of politics, policy making, and women's bodies. So at that, I'm going to start with sort of an overview of why I'm working on hysterectomy. And it is really something I stumbled upon, I would say, about 16 years ago when I was working for the Self-Employed Women's Association. So this is a trade union of women workers in the informal economy, agricultural workers. You can imagine the poorest of the poor. And we ran a microinsurance program for our members. And what I found one day, just in a routine analysis of claims, was that hysterectomy was the leading claim for women. And these women were rural women in their mid-30s. And that really shocked me because I hadn't seen that. We hadn't heard of hysterectomy being conducted amongst women workers in the informal economy. And that at that moment, I went and I spoke to members, our members at SEVA, who were mostly agricultural laborers who were getting the hysterectomies, to understand why. And one, I found out they were very young. They were in the 30s. And the second reason was that it was really tied to their work. And that led to my starting to work on the first sort of prevalence study in the region, where we did an epidemiologic study followed up by years of work. And I've still been at it. And I'll sort of take you through the journey. But really, the reason I call it a puzzle today is that it really is a puzzle in terms of trying to understand a complex issue, like most issues in public health or global health, where it's a complex issue that deals with politics, with social aspects, cultural, economic, epidemiologic, physical, body, etc. And how do you put together the pieces in a way that's useful and doesn't remain an academic exercise, but actually allows us to think about meaningful interventions in the context in which it's occurring. And that's really why it's been a puzzle. So what I'll do today is give you an overview of sort of the lay of the land in terms of the issues around hysterectomy, and then focus on two sort of angles. One is around just surgical intervention in women's bodies and thinking about medical intervention. And the second is thinking about the variation in subnational health systems. So in a country as diverse as India, how does that play into what we're seeing with the variation in the procedure in terms of not just policy making, but also federalism and thinking around different contexts across different states. And lastly, tell you a bit of the policy story that many of us have been a part of in India, to give you a sense of the real life view of what's happened over the years. So hysterectomy is the removal of the uterus, and it can be also of ovaries, the fallopian tubes, different parts of the reproductive system, basically. And depending on the indications, it's used for a range of issues of gynecologic ailments, so for cancers, but also for things, depending on the case, fibroids, etc., and different gynecologic ailments that aren't solved through other interventions. It is the most common operation that women undergo after cesarean section. So it is incredibly common if you look at data almost anywhere around the world, you'll see that hysterectomy is the most common operation in insurance, for example. So it's not exceptional to be talking about it as leading claims, but it is sort of the factors around it. And the reason I study it, and I think this quote has always stayed with me, it's from the late 90s in the British Medical Journal, and someone commenting on hysterectomy in America. And to study the indications for hysterectomy is to really study the interface between medicine and society because of all the issues that it raises. This is the prevalence of hysterectomy in high income settings. So this is the US where we're talking a woman, by the time, these are the eldest women, but a woman by the time they're in their 60s, for example, at least 1 in 3 would have had a hysterectomy. So it's quite common. But that's US, but you look at this massive variation across countries in high income settings, you'll see this wide range, between the US, Canada, here's Germany. And then interestingly, when you really dig into the data, you see a really wide variation within countries as well. Higher in the American South, higher in certain republics in Germany, in Western Australia. So you see variation within, but you generally see these rates. Now you go to low and middle income settings where actually we have very, very little national data on hysterectomy. India is actually the only country that collects data nationally on the issue. But where this is Barbados here, where you see 30%. And I just spoke to Yvette Cozier at the School of Public Health, who asked me about Barbados in particular, because there's also high rates of other surgeries there. So you see, but mostly in low and middle income countries, you see two things. One is it's much lower than in high income settings. That's kind of obvious between the two. These are exactly scaled the same, but also a variation, for where we have data. So these are some Indian states. We assume something higher in the Caribbean, very low in Egypt, El Salvador, and China. So this in of itself is a puzzle as to what should be a regular gynecologic procedure used for very specific indications, used very, very differently around the world. And that also raises some of the questions. And there's no such thing as a sort of benchmark that this is a normal rate, that for a while for cesarean sections used to be in place through WHO that you shouldn't go above, 15%. That's no longer the guideline, but there is no sense of a global benchmark. It's also been a real flashpoint or lightning rod, really, for women's health globally. There's this book written, this is about hysterectomy in America, about unnecessary hysterectomy, called Misinformed Consent. And when I remember reading the stories, it was like reading my own research in India. Hysterectomy and hysteria, if any of you know the link, but there was this idea that women were hysterical because of their wandering wombs. So if we remove the wombs, it would also deal with women's, hysteria and their sense of whatever mental health issues people thought women had. That's an article from The Guardian in the US, where there was an inquiry over 25 years, a scandal of really high rates of hysterectomy in a certain hospital in England. This has happened in America very recently. This is women detained by ICE undergoing unnecessary gynecologic procedures, and also in Australia. So this is something that's been a controversy and an issue globally for different reasons, but very similar in terms of thinking about our treatment and understanding of women's bodies and the idea of control and what's useful and what's not, and what's removable and what is not. Now I'll take you to the context in India. So this really hit the press, and it is rare for a public health issue to get this much press. For those of you or from India or familiar with India, you don't see health reporting that much. It's increased in, I think, recent years. But since about 2010, so at least 15 years, there was this big scam or scandal around health insurance, where, as you can see from some of the headlines, that there were fact-finding missions and activists really uncovering these high rates of hysterectomies through insurance schemes amongst young women in certain states, but there were really small pockets, and it was difficult to understand what was going on. My study, and along with others, we were doing some small community-based studies at the time where we didn't find high prevalence at all. And that's a really important fact, because you see these fact-finding mission and these like really high media intensity reporting that this is a nationwide scandal. But when you actually went and did the epidemiologic study, you found, okay, the prevalence isn't actually that high, but there are other issues that I'll get into in a minute. There's also, again, uniquely, a public interest litigation filed in the Supreme Court in 2013 by colleagues of mine who decided to use the courts to try to address this issue because there were still cases, even one case is too many, of unnecessary procedures done on women. So this was filed in 2013 and recently disposed of, which I'll tell you about in a minute. And we started collecting our first national data through the National Family Health Survey, which is the Indian version of the DHS, or I should say the erstwhile Demographic and Health Surveys. We started collecting this in 2015, so about 10 years ago. And that was a big win because we had national data. And as I showed you, very few countries collect this data nationally. Again, because it wasn't seen as it's a common procedure and perhaps not as high priority to look at. So I'll give you a sense of what we found. These are the patterns. So this is India, and those are all different states. And the dark orange states are where the prevalence is. This is amongst women who are between the age of 40 and 50. So by the time, you hit the age where you would have had a hysterectomy, here about 1 in 5 women have already undergone the procedure. That's a very high prevalence, even by global standards. That's about 20% of women. That's what you saw in the UK at times, for example. Then there are other states where the prevalence is a bit between like 15 and 20, and then the rest of the country. So for those of you who are interested in subnational work, you say, well, why is there so much variation in the country? I'll talk about it. And the only reason I'm showing you this is amongst older women to show that things have changed over time. So you actually saw higher prevalence probably earlier in an older cohort of women, which is also an interesting, again, puzzle to me, which is why was there this change in time? And why do we see certain states persisting with these really high rates of hysterectomy? The real issue that I found from the prevalence studies, the epidemiologic studies, is the age at hysterectomy, because the median age we were talking about in studies range from 34 to 37, certain states in India around 32. Now, most women go through menopause around 47 or 48. So what a hysterectomy at that age is essentially doing is putting a woman, if the ovaries are removed, into immediate menopause 15 years before she should be. So there's no estrogen. And there are a whole host of health issues that, occur because of that. And even if the ovaries are preserved, there is one doctor in the room, there's still a lot of evidence now to show that that still accelerates menopause and, results in sort of a decline in estrogen. So this was the thing that really made us fall off our chairs to say, why is it so young? It's not just that it's happening, because it actually wasn't happening at really high rates across the country, but where, is happening, women are quite young. Then the second thing that was concerning is what it was used for. As you can see, about half of women, when they self-reported, why did you have the hysterectomy? They said excessive bleeding and pain. These are common gynecologic ailments. These are conditions that are largely amenable to other treatment. Of course, we don't have medical records, so some of these were probably quite indicated medically necessary. But one can assume the combination of young age and common gynecologic conditions, the natural assumption we would make is that a large proportion of these surgeries are not needed, and certainly not needed at that age. The other problem we found, there's a data scientist, so there's all odds ratios up there for you, but for the rest of you, you can ignore the table, is that we saw higher risk amongst women who have already finished their families, have less education, actually the least educated. They live in rural areas, not urban. That was the first reaction I would get is, oh, this must be an urban issue. And it actually wasn't, it was rural women. But they have slightly higher wealth, so it's not the poorest, because again, there's an affordability issue. And they're women who haven't already undergone sterilization or tubal ligation, which is the most common form of family planning in the country, as Shreya's PhD will tell us. But this is, to us, when we saw these data for the first time, it raised a lot of issues around equity. It's the most vulnerable. This is the same story in the United States, where it was higher amongst African-American women, or in Western Australia amongst women, Aboriginal women, or women with less education or live further from clinics. So this has been the pattern globally in a way, that those most vulnerable, for different reasons, are more likely to undergo removal of their uterus. We also found in India that about 80% of women, let's say if I just look at the high prevalence states, went to a private facility, not the government. Now, for the poor to be accessing a private facility in India is going to be more expensive, but it's also very common. I mean, our health system is very privatized. So this in of itself wasn't surprising, because most healthcare is sought in the private sector. And as you can see, in all of India, it's about 1/3, 2/3 are seeking the private sector, 2/3. So you see that variation as well. So basically, like a summary of what we know from a population standard, I suppose, standpoint is one, that there's a high diversity and prevalence of the procedure. Very high in some states, much lower elsewhere, which is, it could be a question of access and also no access. So it's not just a question of overuse, it's also a question of those women who may need the procedure. A low median age across states, and then a lot of variation by socioeconomic status, rural, urban location, and education levels, all of which, for anyone in global health or thinking about public health issues, raise a lot of signals right away that there's something going on in terms of access to quality care. Now, so why does this matter? I'm asked this question a lot. I mean, it looks like this room, people look concerned, but often when you raise it as a public health issue, you say, well, why does it matter? I mean, it is perhaps an unnecessary surgery. But what we do know now from a growing body of evidence globally is that women who undergo early hysterectomy have a much higher risk of a whole range of non-communicable diseases, including cardiovascular disease, stroke, potentially all-cause mortality, which has been seen in Australia, for example. It also is a story about women's bodies and the norms around how we intervene in women's bodies in medical interventions. It's a story of health systems in terms of equity and variation, as I just mentioned, and of course about ethics. So why it matters for different reasons, but it's certainly quite an important public health issue. And I think, at least in India, it's been given that priority in terms of an issue that really needs to be addressed and invested in, which is really encouraging. That after years of working on the issue with many people around the country, we are seeing a lot of movement in this area. But just to talk about the effects on health and well-being, just to really put that, this is a sort of figure that came out of work being done out of Australia, and then a consortium of researchers around the world who are looking at the links between everything that happens in women's lives, in their reproductive lives, and how it actually links to later health in later life. So these links aren't always made. It's seen as almost reproduction sits on its own, and then the rest is just men and women are similar. But actually, reproductive events, there is a lot of evidence to show, for example, that the age at your first period is also linked to your risk of certain hormonally linked conditions, whether it be certain cancers or cardiovascular disease, etc. And then so the hysterectomy work we're doing is also within this framework of thinking about this in a life course, rather than looking at one surgery and just sort of focusing on that. And there I've summarized some of the global reviews of data that do show a risk of all of these issues if you've had an early hysterectomy. So it's quite dangerous for women from a long-term health perspective as well. So for example, this is what I found in India, that a woman with hysterectomy, and this is correlations because we only have a 1 point in time data, but we're seeing higher odds of hypertension, of diabetes, and of bone and joint disease amongst women who've already had hysterectomy. So again, you're seeing these links between what tend to be a focus on reproductive health with health through the life course. So bringing me back to what Joe had asked me earlier in terms of policy and globally, it's not just about a specific gynecologic issue. It's about looking at women's health through the life course and all health through the life course. Frankly, it's not just women. And in India, we have that potentially more problematic issue of the age at which it's being conducted. So you may see, for example, the menopausal years, which would start around here, which is what we traditionally consider reproductive age in global health. And this is one of my sort of commentary. Sometimes when you think of things globally, think 15 to 49, these are the reproductive age years. But actually, in situations where hysterectomies are being conducted here, those end. And you're talking about a complete shift in even the life course and how you think of age groups in different contexts and the health needs. So it's not really numbers as much as it is life stage. I think that matters. And that's something we've learned a lot in India and made us pull back from some of the global approaches to looking at these issues. And so even in our surveys right now, we're actually asking women about their lives through stages: after your first period, after your children, after you were sterilized, before you were X, rather than the age at which it happened, because that's actually the way to understand the life course, is by specific events. And now I'm going to talk a little bit about sort of how we think about it in terms of the body and what I've learned over the years from my research. So these are two quotes, and I won't read them out for those of you who can see. But this is from interviews I did about 10 years ago with agricultural workers. And women, an agricultural laborer here at the age of 22, when she had a hysterectomy, so an extreme case, but kept talking about work and labor, that working was a problem. So I thought to remove it because she went to a doctor who said, well, if you don't remove it now, you'll have to eventually. But she negotiated. She went to different hospitals. She didn't want to take short-term medicines or short-term sort of procedures, but rather thought, well, what's a long-term, in quotes, pragmatic solution to this issue? And you have a health system that is not geared to address some of these issues. To me, this quote encapsulates all of the issues we've seen around, one, a health system that can't cater to these issues, and two, when you look at women in work and the sort of the burdens on time and also that health can cause, the operation was seen as something to be healthy, as opposed to some, rather than thinking about it in any other way in terms of long-term effects. And then a doctor, again, from a doctor I met in a rural clinic, and this is again quite common, so this is not an exceptional quote at all, is that if a woman has had her kids and she's above 35, you do the full hysterectomy to be safe. It's almost seen as prophylaxis. So the sense that you remove it so then you're safe because you might not get cancer later. But really what it's at the core of both of these quotes is the idea that the uterus is dispensable, that you don't really need a uterus. Once you've had your children, you're no longer, I always say you're only productive till you're reproductive, and then that sort of productivity potential is not there. So why do you need the surgery? And I believe in the US, it's called the Mississippi appendectomy. In the South, because it's just so common that women at an earlier point were getting hysterectomies in that way. You don't need it. It's a dispensable organ like an appendix. And that is a very common refrain that I hear, across, and again, not just in India, but across South Asia for sure, from colleagues, and I'm sure in other parts of the world. Once we start digging, it'll be interesting to see. When we have been speaking to women a lot right now about their attitudes towards menstruation and the uterus. And it was interesting, they're all very, very mixed sort of responses from the same women around, well, menstruation signifies womanhood, it purifies your system, but it's also the source of troubles and it can be quite polluting. So in India, there's a lot in certain areas of the country, in certain communities around the idea that menstrual blood is polluting. So also menstruating means you can't enter a temple or you can't cook or you can't touch certain crops. So it's seen as a source of problem. So the hysterectomy also solves for that because you no longer bleed. But the uterus, similarly, it's also a sign of strength, but the source of troubles, particularly amongst women who have very real gynecologic issues. So this is really vexed, and it's not a simple line. And I found this is from 3 different states in the country, and we did even see variation in those 3 states. And just to bring it back to global health for a second, when we talk about parachuting and people parachuting into one country, and that's a problem for us, even within India, parachuting into different states is an issue. And you have to do the formative hard work before in different contexts because it is different. And that really influences the way we even do something like a survey. And we've also seen that these attitudes are changing. They're different amongst younger women than older women. But that sort of quote I have up there, the idea that women are tired of menstruating, well, just get the uterus removed. It's sort of a solution. So this is a sort of overall of, there are very few qualitative studies in the country, but the sort of synthesis that a colleague of mine had done basically came to, look, there's 4 factors at play. It's women who actually have untreated morbidities, but there's also fear of whether it's cancer later or any sort of issues that they may have around their own health. There's social taboos, the idea that uterus is reproductive. You have providers, the healthcare providers, in terms of their incentives, perhaps. I mentioned it only for a second, but there is also the financial incentive if insurance is involved, which has been, again, seen in many parts of the world. In India, the reason I didn't mention it, because the health insurance policies have changed recently in terms of their coverage for hysterectomy. And this is sort of the theme of what you keep hearing, that it's pragmatic, it's prophylactic, it can be preventive, or it can be permanent. But these are sort of themes of the problematic practice of how we think about women's bodies, in the sense that they're obviously to be operated upon because it's pragmatic. So this is not, I'm not going to go through this except to say, when I've been trying to grapple with the puzzle and trying to break down different ways of thinking about it, it's socioeconomic, it's health system, it's individual, social, I bet you would add political, and the policy, and there's so many different ways to cut it. And I think that's in one of the things one struggles with, because you also need to be pragmatic in terms of the presentation of the issue when you're trying to make change at a policy or health system level. So which is the best approach? And, despite trying to understand it from many ways, my approach tends to be, at least in the policy story, to focus on the health system side, because that's where you can actually talk about, because I often get well, what do we do about it? So now I'm going to talk a little bit about state variation. I purposely, as a joke, have Brenna's book up as a cover, as someone who's worked on state variation, but there's also a great piece of work done years ago around nations within a nation and just variations in the epidemiology and the epidemiologic burden within India. So there's, the importance of really understanding the variation. And to me, the reason I study variation in many different health issues is because I think therein lies some of the potential for interventions and some of the things that can be actually worked on or changed, depending on the issue at hand, to be higher or lower. This is the spread of hysterectomy amongst women 40 to 49. I mean, just look at that spread within Indian states from 22.5% to 2.5%. Which is really interesting. I mean, sure, states are different, and anyone who's familiar with these states, you will not be able to solve this puzzle because it's not economic, it's not political. I mean, it's really interesting in terms of just trying to understand why is this the case. So this is the reason we use this age group, is because it's the prevalence at that point in time.
Okay.
But their age at which they got it would have been in their 30s.
Oh, I see.
So it's
Got
just a
it.
point prevalence, yeah. So it's just easier because that's the group that's highest at risk in a way of they've gone through those years. But it's similar patterns if you were to look younger. So I tried to look at state level factors, just doing some basic statistical work, and what came up, and trust me, it is very, very difficult to come up with anything that's a clear line. But we saw potential factors, states in which C-section was higher. So there are more cesarean sections in that state. You may see more. Where education, lower education. So you had more women who were less educated. Higher proportion of women in the workforce. There's someone who works on the workforce here. Health insurance has been a big question mark because it's been difficult with the data we have at hand to understand the role of health insurance. This is all to say, frankly, it is very difficult to understand what drives the variation, and I'll tell you what my hypothesis is in a minute, but it is something we're still grappling with. And what I'm doing right now is actually studying 3 very diverse states in the country to try to understand why all 3 have high prevalence, but very different contexts. Now, this was a graph that I wanted to do in animation, so I apologize in advance because it's hard to see them all together. So I'll talk you through it. This is the spread of cesarean sections in the country. So the dark orange is the states who are in the top tercile. So you see these are states in the south, but you see some here, and then all the way in the north, you see high rates of C-section. Now, these are the 3 major medical interventions on women. Surgical. Now, this is not just contraception. This is specifically sterilization, specifically tubal ligation. You see, these are the states. It's the most common form of family planning, but you see it's much wider spread, because it has a different political history, it has a different health system history as to why sterilization is where it is. And then you see hysterectomy, where, again, these very diverse states, but it doesn't even add up across these. But the other story it tells me, it's not just the state diversity, but it's also when we think about women through the life course. So you start around pregnancy. We've had a lot of policy around pregnancy and investment. So you're seeing C-section rates actually now go up and up over time. Sterilization, that's the next thing we cared about, which is, okay, you've had the babies now to ensure that it's a permanent form of family planning. Sterilization is quite common across the country. And then when we go beyond reproduction is where you start seeing less policy attention, less investment in general, but you do have certain states already where you're seeing overuse of certain procedures. But my fear is that you're also seeing a lot of states where there's probably too little use of procedures because you just don't have access for the same reasons. And I tried to map hysterectomy to health system performance. So those of you interested in universal health coverage, this is the UHC index. It's the World Bank WHO index that we adapted with colleagues to the district level. And these are all the districts of India, and the green are the highest performers. But if you do a quick map, it doesn't make sense either in terms of health system performance, whether that's coverage of insurance, its access, etc. So again, this is the puzzle that I'm personally grappling with and trying to understand right now through a sort of mixed method study over the next, well, it's 5 years, but it's been a couple of years already. So I leave you at, in terms of understanding state variation, I'd say, well, I'm not sure, but I do think there's probably 5 factors that matter, and you have to have at least maybe 3 of the 5 or 4 of the 5, perhaps, to see that explosive combination. And this is something that should be tested, I think, to understand Germany or Australia or America in terms of wherever we see this variation. What is it that results in high use of procedures that are interventionist and can be unnecessary in women? So now this is the sort of puzzle and the issues that I'm going to switch gears for a second and talk about the policy story, because what we have 2 years ago, the government of India notified policy guidelines to prevent unnecessary hysterectomies. And this was a big, big win. And this was actually in response to the public interest litigation filed in 2013. It took a while, but what we did see, and I think it was, and I want to tell the story because I think policy making and what happens and how evidence actually translates into policy, it's obviously not a straight line. It's never one piece of that puzzle. It's always so many actors and stakeholders at play. And I don't think there's one push. So I'll tell the story that I happen to be witness to with these guidelines. And these are official guidelines that actually call for audits and monitoring committees to be set up in every state and every district of the country, that any woman who undergoes a hysterectomy under the age of 45 or 40 that hysterectomy has to be reported. And then there's a sort of audit committee. These are just in the process of being set up, so I can't say I can share much about what we've been finding, but the fact that the guidelines call for this, they also call for standard treatment protocols. I mean, there's a lot of normative work that's gone into the guidelines, and they were developed with a really wide range of experts working on the issue. So it's really quite laudable to see that the years of activism, evidence, and other factors at play actually contributed to seeing a really strong policy response. PMJY, which is our insurance scheme, also limits coverage now and increases checks on hysterectomy. I will say we've had 2 rounds of data collection and then a 3rd underway right now. We haven't seen a change in the prevalence yet. I'm very hopeful, but we haven't seen one yet, which also means that it's clearly not just financing, or it's clearly not just one factor. There's several factors at play. OPSI, which is the national sort of Federation of Obstetricians and Gynecologists, also created a campaign to save the uterus. And again, so to answer your question about engaging, they're very engaged in the issue and putting it out there as a campaign to talk to doctors about. So you have seen a response, but how did we get here? And I would say the story started at least 15 years ago. Some will argue even longer, because there were sort of some very scandalous cases around hysterectomy much earlier, around cases of women with disabilities. But what we did find about 15 years ago, colleagues of mine did fact-finding missions around the same time we were doing epidemiologic studies. And then we came together over these years, and I'll take you through the steps, doing different things. I would say it was the health ministry was involved. It was the creation of evidence. The media played a role. I can talk about that. It was a vexed role. Legal action, using the Supreme Court, civil society really being sort of focused on the issue in small pockets, and also the professional bodies. And I would argue that we needed all of these to see this change. And it's that A, you needed all of them, and B, it's a really long arc. So it's always laughable when a donor asks you, well, what is the impact of that study? For those of you in public health, what has been the policy influence? Well, it takes a really long time, is always my response, that these are not things you'll see movement. You can engage for sure with the evidence and engage the right people. But to imagine influence impact, I think, is a 15-year arc at minimum, and I don't know, depending. So the evidence story is interesting, and I think for those of you in the room, from different perspectives. So it started with little pockets of community-based research, but we actually actively advocated for national population level data. And it actually was quite simple because the DHS, the NFHS, the National Family Health Survey, was already doing large surveys in the country. It was the insertion of 3 questions. And similarly, the longitudinal aging study in India that surveys women 45 and up also had questions on it. So all of a sudden, you finally have these data, because without these data, the smaller studies were always brushed aside as well. That might be an issue there, but is that really the case across the country? And what that also told us, it actually isn't the case across the country. It's quite variable. So it's important to know that as well. And also there's been support. So the government of India, with the Welcome, is it funding me and several colleagues, a large consortium of us, to actually study this in a much more focused way, looking through the life course in 3 states over the next 5 years. So you do see that sort of movement, and I think that's a positive story. The media. So this hit the media, starting with Al Jazeera, so the global international media, Al Jazeera, BBC, they've all done documentaries. The New York Times just did this long series of articles. And I have a very, I think, a complicated reaction to it, because on one hand, I remember very clearly when the ministry convened to discuss the guidelines the first time, it was in reaction. I mean, wasn't in reaction, but someone had noted very clearly that there was an article in the Indian press that really bothered them, because it was that, I mean, no one is reading all of the literature and the academic literature. So it's very important that this was reported on. But then how do you report on these issues that are very complex in a way that's also sort of media friendly, which has to be eyeball grab? So it started becoming like, look at these headlines. And, I just, went through 45 minutes telling you of how complex the issue is, how varied it is, and how nuanced the response needs to be. And then you get these headlines about farmers going wombless. And it really becomes difficult when you're sitting on the front lines trying to work with policymakers or work with providers who may think you're also simplifying the issue. But from the media's point of view, it obviously has to be a story. And it's a very complicated, and actually a colleague of mine is trying to do a media analysis right now to try to understand how has the media reported on this over the years, and how do we do it in a way that's useful, but also, I think, faithful to the nuance. And it's difficult, and I'm sure you sense that in other areas as well. But it was a big part of it. We also convened civil society, researchers, and government 3 different times, starting in 2013. And these are just photographs of consultations we did nationally to understand the numbers, but also at the state level. So there were 2 large national ones and then 6 state level ones. And this was so important because it has to be an issue that others are invested in discussing and thinking about in a way, but it really had to be through these convenings. And I always say they were coalitions that made change. It was never one stakeholder. Any of those 6 stakeholders listed did not have the sort of positionality to really make this change without working with everyone. And I think it's a great story of partnership, to be honest. There are many interventions that have been tried or being tried. One is the first, looking at information and just giving women basic information on what a hysterectomy is, because that's been one of the big barriers. A lot of people will not know what those side effects are in particular. The second is to think about clinical guidelines, so women have access to options in the health system. And that's really where my focus is right now, for example, is to really work with people to push for the actual alternatives that are possible, as well as clinical governance. I think a lot of hospitals are thinking about ways to actually internally audit rather than having external audit, which seems more difficult to implement in a wide scale. So this is sort of answering Joe's last question to me is, well, where do I see this going now? And I think these are the new pieces of the puzzle that I'm trying to work on with many colleagues around the country and in different places, which is how do we move this towards not thinking about one thing or not thinking just about intervention in a negative way, but how do we move toward an understanding of women's health? And for context, most countries do not have a women's health or a men's health strategy or a gender and health strategy at all. So in India, I mean, this could be a place to also think of creating a momentum around things around accessible treatment options, if shifting the way we think about the body and the idea that the uterus is not dispensable, mean, that is a really important start. Also, seeing those national guidelines just on paper isn't enough. We actually now need to support the implementation, which I suspect I'll spend the next 20 years working with partners on, and that's fine. Because I think when you want to see something through its entire course, this is what it takes. Bringing out the evidence on the consequences in particular and the consequences on women's health. And then, as I mentioned, also doing consultations and thinking about knowledge exchanges in other low and middle income countries that are likely facing similar issues to ensure that there's more thinking around this where we can learn from each other, I suppose, as well. And also from countries where we've seen rates go down.